Hi everyone, and welcome to the debate of the use of restraints and seclusion for people with autism and other developmental disabilities. We will be conducting an informal debate using me, Callie, as the introducer, Cheyenne, the fielder, Shay, the researcher, Ariel, the illustrator, and Maddie, the summarizer. The pro side of this debate is that restraints and seclusion provides a safe environment for students and staff in the classroom, as well as the student engaging in the behavior. The con side is that restraint and seclusion causes psychological and physical damage and injuries to the student. I'm going to start by introducing the pro side of this debate with an article called Analysis of Heart Rate and Self-Injury with and Without Restraint in an Individual with Autism. In the article, it stated that restraint and seclusion provides a safe environment for students and staff in the classroom and student engaging in the behavior. Restraints act as a negative reinforcer for self-injury. Along with preventing self-injury, it also prevents aggression towards other students and staff, as well as property destruction. I am now going to read a scenario from a pro-restraint article called The Long-Term Successful Treatment of the Aggressive/Destructive Behaviors of a Pre-Adolescent with Autism by Richard M. Fox and James Mendel. The scenario is that physical restraint was implemented whenever Johnny's aggressive or destructive behavior escalated to a point where he posed a danger to himself or others. During this procedure, Johnny was placed on a mat in a supine position with one staff person restraining each arm and a third person restraining his legs. No one spoke to Johnny, and he was physically restrained until he had achieved a state of calmness so that he wouldn't be reinforced by the removal of restraint. Because Johnny had a history of arising from restraint and immediately attacking others or becoming destructive, a compliance component was added to the restraint procedure. Thus, once the restraint ended, Johnny was required to comply with a series of instructions presented in rapid succession. The purpose of this tactic was to establish compliance before he returned to his educational activities. Whenever physical restraint was implemented, the antecedents and consequences surrounding the aggressive behavior, the time of day, and the length of restraint were recorded. All restraint and behavioral data were provided to members of Johnny's IEP team on a weekly basis, and monthly summaries were provided at IEP meetings. Johnny was aggressive for the first day of treatment, and physical restraint was implemented 9 times for a total of 180 minutes. On day 2, physical restraint was implemented 5 times for a total of 47 minutes. On day 3, physical restraint was applied once for 14 minutes. No restraint was necessary on day 4, and only 2 on day 5 for a total of 14 minutes. During the remainder of the first month of treatment, 1 physical restraint was applied on 6 separate days for an average duration of 23 minutes. No restraint was implemented during month 2, and restraint was implemented only 6 times for a total of 162 minutes in the remaining 10 months of treatment. No restraint was implemented in 7 of the 8 last months of treatment. Currently, 1 floor mat remains in the classroom, and it is used for Johnny's morning exercise routines. This scenario shows the positive outcomes of using restraints and how it decreased Johnny's maladaptive behaviors over time. The article, Characteristics of Adolescents Frequently Restrained in Acute Psychiatric Units, describes the different types of restraints. The first one is mechanical, which it inhibits the patient's freedom of movement, including belts and straps and clothing especially designed to prevent injury. Physical restraint refers to any technique in which staff members physically restrain a patient without using tools. Seclusion refers to a detention for a short period of time behind a locked or closed door without a staff member present. We are now going to move on to the fielder, Cheyenne.
So my first question is, how does the use of restraints and seclusion uphold the core ethical principles? And the main code that supports this is code 2.09, which is treatment and intervention efficacy. So the client has the right to an effective treatment. 2, in those instances where more than one scientifically supported treatment has been established, additional factors are going to be considered in selecting interventions. And then 3, the behavior analyst reviews and appraises the efficacy of that treatment and how effective it actually is. Some additional questions that Shay is going to talk about is what are some forms of restraint and seclusion that have been found to be effective? In what situations does seclusion or restraint help with problem behaviors? And then how effective are restraints in seclusion?
So I'm going to answer these questions by reviewing 3 studies. The first study I'm going to start with was by Fisher et al. In 1997. He had 3 clients who engaged in severe self-injurious behaviors, which included hitting their heads, their faces using their fists, banging their heads on surfaces, and scratching to the point of marks on their body or bleeding. So in these cases, they were given mechanical restraints, which were arm sleeves. The arm sleeves have had 3 different varying levels of rigidity that included a sleeve with 1 metal stay, a sleeve with 4 metal stays, and 1 thick metal stay. So the point of this was to eventually reduce how severe the mechanical restraint was. So for this, their behaviors interfered with their completion of tasks. So that's what was targeted. So they were completing tasks when they had these sleeves on. And after completing the tasks, they found that there was a decrease in self-injurious behaviors and an increase in the completion of the tasks. They faded the rigidity of the sleeves over time, and even after doing this, they still saw low rates of self-injurious behaviors. So fading the mechanical restraint in this particular study was an important component because it still decreased the behavior. So they were using restraints, but it wasn't as severe. The next study, which happened to be 10 years later, was by Fox and Mendel. And this was a single subject design with only 1 boy. And this boy had self-injurious behaviors, and he was treated with various interventions. So it wasn't just restraints. His behaviors included hitting, kicking, headbutting, biting, and using objects as weapons towards himself or his staff members. Some interventions that were used included a token economy, a DRO of 5 minutes in which he could not engage in any destructive or aggressive behaviors, a response cost where all his tokens were removed, overcorrection, and physical restraints. Physical restraints included a supine position restraint that was completed by multiple staff members. The restraint, if they used the restraint, the supine position restraint was used until the child was emitting calm behaviors in which they felt safe and they felt like the child could continue throughout their day. With the combination of all of the interventions, his self-injurious behaviors drastically decreased. So from the first day, they had to use 9 physical restraints, which resulted in 180 minutes of restraints. So that could mean that each time he was held down for all of that time across the 9 times in the day. But then the next time that they reviewed it was over 10 months. So we're talking 1 day versus 10 months. And in 10 months, they only had to do it 6 times. So they reduced it drastically, which means that they used it, but they relied on the other interventions as well. So in this particular study, a combination of multiple interventions was really important. The final study was by Jeanette et al. In 2011. And this author showed that individuals who admit self-injurious behavior have lower heart rate. So in this particular study, there was 1 girl, and she had her heart rate monitored throughout different points of the day. She had mechanical arm restraints that she wore for her entire day. So her behaviors were so severe that she was removed from her school setting. So the arm restraints had to stay on her even in her home. She had 24-hour care in her home as well. So she wore her mechanical restraints and had a heart monitor on her as well to see what happened with her heart rate. And the results were pretty interesting because if the restraints were removed, her heart rate increased. So that meant when she had the restraints on, her self-injurious behaviors were much lower and her heart rate lowered as well. Interestingly, even in a condition where they removed it but applied a physical restraint from the staff member, her heart rate still returned to a normal state. So in this particular case, this individual, it was really beneficial for her to have either a physical restraint or a mechanical restraint, and it had physiological effects on her heart rate. So in this case, mechanical and physical restraints were beneficial for her, and it also decreased her severe behaviors. So now I'm going to pass it on to Ariel, who's going to review illustrations from studies.
Okay, so I'm going to show you guys the study that Shay had just referenced where they had no sleeve, sleeve, one metal stay, four metal stays, and a thick metal stay. Um, on this chart here, there is a line labeled for their level of compliance and a line labeled for their SIB. As you can see, the SIB is very clearly decelerated to nothing as they continue to add stays. The as Shay mentioned at different points, the decrease of injury to the client and others is an extremely important subject to consider. Rosa et al. 2015 mentioned clients in the study were able to decrease SIB with simply the presence of a flexible sleeve and increase compliance in different tasks. The presence of mechanical restraints, seen in the graph depicted, illustrates the impact of a restraint and how it can make reducing self-harm pretty instantly. When we think of Ethical Code 209, which is treatment, intervention, and efficacy, the ideal of do no harm goes along with that. And we have to think about what treatment is best for the client and how they can function without self-harm. Given the negative side effects of SIB, restraints may still be necessary in some cases. And as you can see here with this graph, it clearly illustrates how they were able to comply with demands still and be in a position to protect themselves. So now I am going to turn this over to Maddie.
I'm going to go ahead and wrap up the pro side here by just giving a quick summary of everything that was discussed. So it was brought up there are 3 different types of restraints. We have a mechanical, a physical, and a seclusion. Mechanical basically inhibits the client's freedom of movement, and this could be used with a strap, with a belt, or something clothing-wise that's specifically meant to restrain movement. A physical restraint basically refers to another human or staff member coming in and physically restraining the client. And then seclusion refers to basically putting a client in a separate room where the door is closed and it is just them by themselves. It was reviewed how restraints can provide a safe environment for clients who engage in severe SIBs and aggression towards peers around them. And it showed that mechanical and physical restraints were used in multiple studies that were brought up, and it helped reduce the presence of the SIBs and aggression towards peers because it was restraining them from being able to engage in these behaviors. It also showed in these studies how it reduced the frequency. As Ariel brought up those graphs, you saw it was high rates of SIBs. And in a couple of the studies that were brought up, each client was used some sort of restraint, whether it was physical, mechanical, or seclusion. And as they used those, you saw not only a decrease in the SIBs, but when the restraints were taken off, you saw there was also lower rates of SIBs without those as well. Some of the code violations that were brought up were Code 2.09, which has to do with treatment and intervention efficiency, and it discussed how you have a right as a BCBA to provide the utmost treatment for these clients, and if seclusion or if restraint is what's going to be best for that client, although it could be a little severe, it is something that's going to keep them safe, and that's very important, and we need to follow through with that. I'm also going to move it on over to Callie now, who's going to introduce the con side.
Like Maddie said, we're now going to discuss the con point, which is that restraints and seclusion causes psychological and physical damage and injuries to the student. I'm going to read 2 scenarios from a con restraint and seclusion article called Human Services Restraint, Its Past and Future. Isaiah Simmons died January 23rd, 2007 at the Bolingbrook Preparatory School in Maryland. He allegedly acted out in the dinner line and was restrained. 4 youths who witnessed the incident said that staff sat on him for 3 hours until he passed out and died. The school has closed. The death was ruled a homicide, and involved staff were charged with waiting 41 minutes before calling 911 about the unresponsive boy. They were later cleared of criminal charges. Another instance from this article states that on June 3rd, 2007, Omega Leach, age 17, died at the Chad Youth Enhancement Center in Tennessee, a day after being restrained for 7 to 8 minutes for attacking a staff member. At the end of those minutes, staff could not find a pulse. The state found that the facility violated restraint policies. These are only two of the many instances that ended in death or injury. We are now going to move on to the Fielder Cheyenne.
So my first question is, how can the use of restraints and seclusion potentially violate the core ethical principles? And I'm going to talk about a couple different codes here. So the first one's going to be 3.01, which is behavior analytic assessment. And the main points under this is that the behavior analysts conduct current assessments prior to making recommendations or developing behavior change programs. And the use of which assessment is going to be determined by the client's needs and consent and environmental parameters and other variables. And then behavior analysts have an obligation to collect and graphically display data using behavior analytic conventions in a manner that allows for decisions and recommendations for behavior change program development. So just making sure that they're representing this data in an ethical and honest way. The next code is going to be 4.03, so individualized behavior change programs, with the main points of this being that behavior analysts must tailor behavior change programs to the unique behaviors, environmental variables, assessment results, and goals for that client. And then behavior analysts do not plagiarize other professionals' behavior change programs. So when they're implementing these programs, it needs to be specific to that client and that client's needs. Next is going to be 4.05, which is describing behavior change program objectives. So the analyst needs to describe in writing the objectives of the program that they're wanting to implement before they implement it, and even explaining all the possible risk-benefit factors that come into play. The last code that I want to talk about for this is 4.09, which is the least restrictive procedures. So the analyst needs to review and appraise the restrictiveness of the procedures that they're wanting to implement and always recommend the least restrictive procedures that are likely to be effective for that client and that client's needs. And then just making sure that they're hitting those core ethical principles of do no harm, being just, according dignity and respect to the client, and accepting that accountability for what they're recommending. My next question that Shay is going to go through and answer is, what are the emotional and physical repercussions of the use of restraints and seclusion?
So the first study, I'm not going to go over the study, but I'm just going to read a statement that was in the article, and that's by Eblin 2019, and he states that the use of seclusion and restraint during psychiatric inpatient treatment increases the risk of trauma, humiliation, physical injuries, psychological distress, and even death. So there's two studies I'm going to review that go over some of the physical and emotional repercussions. The first one is by Tilley and Sprett and was completed in 2009. The point of their study was to review data they had previously taken in which they recorded the types of restraints and any injuries that were a result of those restraints. So in this facility, there are 123 adults that have severe behavior and emotional difficulties. The facility only uses an emergency restraint procedure. So that is if the individual is going to harm themselves or has a potential to harm themselves or others and has not been responsive to a less intrusive intervention, then restraints would be used. So they also reviewed this. So they found that 1 out of 3 restraints resulted in injury that were minor, such as redness, minor bruise or abrasion, and abrasions of 5 inches. So even though they were minor, they still had physical marks on their body from the use of restraints. The other thing that was interesting was anytime they used restraints, it was because aggression was occurring, but there was no previous evidence that they were trying to decrease the aggression. So in this case, they were just treating aggression by using restraints, but not trying to use any interventions that would actually reduce the aggression. So that takes into account of whether or not the intervention really is the most effective, because we want to decrease the behavior, not necessarily just treat it every time it happens. The next study was by DeRosa et al., and that's in 2015. And this study, they had 3 males that had self-injurious behaviors like hand biting and scratching, hitting their head, things like that. Their behaviors were really severe. So they did have to use restraints to kind of shape those behaviors. However, the physical damage of the restraints started to impact these individuals, and as a result, they were fading them. So in the previous studies that we had mentioned so far, fading procedures were pretty common. On this side, on the con side of things, if you are fading and you're still seeing that there are positive results, then it kind of takes into account the question of why are we using them if we can monitor it without the restraints. So some ethical codes that come into play here is 4.08, considering reinforcement before punishment. So what else can we do? Why are we just relying on using restraints? And also 4.09, which was previously discussed, and that's the least restrictive procedure. Obviously, using restraints is not the least restrictive procedure, and using something else is important. And we will be addressing that.
So my next question is, what alternative treatments can we use to decrease self-injurious behaviors without using restraint and seclusion?
So there have been several studies that have reviewed just this and have examined other ways to treat self-injurious behaviors. The first I'm going to go over is by Sullivan et al., and it was conducted in 2005. This was a longitudinal study that included 117 patients that were in an inpatient facility. They examined efforts to reduce the use of restraints and seclusion across the board in this facility. So with all of these patients, the 117, they did not want to use restraints and seclusion and instead wanted to use other interventions. So the need for these other interventions was because there were often altercations between patients and other patients, patients and staff members, and patients with self-injurious behaviors to themselves. So decreasing the use of restraints was important. So the alternative treatments that they used were all based in reinforcement. These included talking with staff, walking with staff, use of timeout or a quiet space, decreased stimulation, and special requests, which could include watching a movie of their choice, calling someone on the phone that they really wanted to talk to, and other things like that. So it was important for all the staff to be well trained on what these alternative treatments were. And these patients had a choice of what they could work for, and they got to choose. So their first thing that had the most choice was talking with staff, and that was 32% of the cases. So that was interesting to me because talking with staff is attention seeking. So they wanted attention from them. So they found actually that if they were able to do that, talk with staff, even walk with staff, or have just some alone time with them, the behaviors actually decreased and the use of restraints were not needed. So that takes into play or into account the function of this behavior. So why are they doing these different self-injurious behaviors or aggressive behaviors against others? And to me, after reviewing this study and after reading their discussion, it seemed like a lot of it was attention. And when they received that attention before actually engaging in any of the behaviors, they did decrease. The other study I'd like to review is by Eblin 2019. And in this study, there were 14 children aged 6 to 17, and they had dangers to themselves and others through their behaviors. And what they did in this study was they came up with 3 different interventions to use. And these included a behavior modification plan, a decision-making algorithm for the use of restraints, and a patient debriefing tool. So the behavior modification plan was like an individualized treatment plan. So they use operant conditioning to come up with what treatments would be on this plan, and every child had something different. So this is really important because their plans were individualized, as they should be. So they used different treatments for the children to see what would work best. The next thing was a decision-making algorithm. So they understood that they may have to use restraints at some times, but when did they have to use it? What did the behavior look like? How often did it happen? How intense was it? The last thing was a patient debriefing tool that was very similar to ABC data, where they took into account the events that happened before seclusion and restraints, what the seclusion was being used for, reason for initiation, and they discussed methods for future episodes. So it was very productive in coming up with different ways to do it so that they really could reduce the use of restraints so that the effects that could be psychological or physical were reduced. So I'm going to pass it on to Ariel for the final illustration for the con side.
Okay, so I'm going to show you an illustration here. Shay had referenced DeRosa et al. 2015 and how prompt fading has been used over time to decrease the use of mechanical restraints and potentially eliminate them. As she addressed, restraints can cause physical damage to the client, including to bones and tendons. If they can be faded, perhaps we can learn to eliminate the use of them. In this graph, it shows how they had rigid sleeves, bare arms, and flexible sleeves. And it illustrates the level of SIB that they had during that time at the top. And then at the bottom, it illustrates the use of another consequence procedure that they added, which was just a water mist as a punisher in order to help decrease the SIB. And it shows how they had the fading and the water mist together at the very end, and you can see there was very little to no SIB that occurred in that last phase with the fading and the water mist. So it's something to think about with how we've been addressing things with restraints and think about, are they really necessary? In addition, Shay had talked about a flow chart that was used in the Eblin study 2019 to address thinking about when restraints are actually necessary. So they asked questions. Did they try to de-escalate? So restraint was always a very, very last resort. So it's important to know when to intervene with restraints. And the fact that the flow chart needs to be used to determine when restraints should be used is an important factor, because we know, as stated in the study, she had quoted how damaging it is, and that it can be physically, mentally, emotionally traumatic to clients whenever those restraints are used. So we need to think about, are they going to cause more harm than good? We may need to address SIB and aggression in other ways, such as through non-contingent reinforcement methods. Now I am going to pass it on to Maddie.
I'm going to go ahead and, excuse me, wrap up the con side here and just review everything that was discussed. So one of the things that we talked about was restraints can cause psychological and physical damages or injuries to a client. And there were two incidents that were referred to talking about where a client ended up passing away, which is the worst case scenario that can happen. And that is something that can happen. And that is a risk that's taken when we implement any sort of physical or mechanical restraint on a client. It's very unfortunate and it's very sad, but that's something that we need to be very aware of when the discussion of restraints are brought into conversation. As well as we talked about a couple codes that were violated. So 3.01, the behavior analytic assessment. As a BCBA, you need to collect your data, you need to have your baseline, and you need to show that if you're going to implement a restraint, here's why we're implementing this restraint. And before that, what other ways can we decrease this behavior using a positive reinforcement before we go to this punishment immediately? And if you're going to bring this punishment in immediately, for example, if you use a physical restraint or a mechanical restraint, you need to have solid baseline data or solid graphing data to show this is why we need it. And you need to be ethical in your ways that you present it. You can't be making up your data. Everything needs to be concrete and present. Another code that was brought up was 4.03, an individualized behavior change. As brought up before, you need to make sure that you take this data, and this data is going to show how you tailor your program to a client. So just because you see somebody who has similar behaviors as your client, and let's say that BCBA used this physical restraint, that does not mean that that's going to work for that client. And potentially, if you all of a sudden make a cookie cutter program per se and take somebody else's to this client, you're putting this client at risk. There is a chance that you could end up having this client pass away because of that restraint if you are just going and taking one thing from one person and passing it on to another. And as a BCBA, you need to look over your clients and you need to make sure that, is this the best result? Am I going to see what I want with this client? Another code that was brought up was code 4.05 in describing the behavior change objectives. As a BCBA, you need to write out from start to finish in detail what you want to use and why you want to use it. You don't want to go into this saying, well, we're going to use this restraint and this is why. You want to break it down. This is why. Here's how it's implemented. Here's how we're going to implement this. This is the exact way to do it. Because if you don't do that, there's a chance that the client could become injured, or psychologically, it can also hurt them that way. The last code that was brought up was the least restrictive procedures. And as mentioned before, you want to use the least restrictive and then make your way down. So if somebody's hitting their head, you don't want to immediately go into this hold on this client, because there are other ways that you can go about this. And that's where that flow chart comes in. Have we done step one? Step one didn't work. Have we done step two? Step two didn't work. Step three worked. We're going to stop there. We're not going to jump down to step 7 in this. Some of the emotional and physical repercussions that were shown with restraints and seclusions were also brought up, and it showed that clients have redness, clients have scratches, clients have bruises. Although these may seem minor, it can be very major to that client. These are things that you're implementing on somebody else. It's not happening to you, and we need to keep that in mind before we go immediately into physically restraining clients, which brings me to the next point that was brought up is alternative behaviors to decrease this SIB. Are there other behaviors? And studies showed that yes, there are. Are there other ways that we can decrease this behavior? And studies showed that yes, there are. We don't need to immediately jump to a physical restraint because, as mentioned, it can cause that physical harm. It can cause that psychological harm. So going through that flow chart again of how can we do this without harming the client physically or psychologically. And the studies have shown, yes, there are other ways that we can do this without jumping into the most restrictive procedure possible. And I'm going to pass it on to Cheyenne now, who's going to close us out.
So I just wanted to present just some additional information here at the end. So as far as just kind of expanding on these definitions that we had for the different restraints and seclusion, mechanical restraints are going to include inhibiting that patient's freedom of movement, including belts and straps and clothing, whatever, to designed to prevent injury to themselves or others. And so with examples being like a chair that includes straps holding the client to the chair, with non-examples being like using a seatbelt when riding in the car. Physical restraints, referring to any technique in which a staff member is physically restraining that patient without using any other tools, with an example being immobilization procedures during crisis, and non-examples being like wrestling for like playtime. Seclusion, referring to detention for a short period of time behind a locked or closed door without a staff member present, with an example being use of a timeout room. And non-examples mean like if your client's using the restroom and they close the door and lock it for privacy, that's not going to be included in seclusion. And then I was able to find just some of the parameters and regulations for some of the states that our group is from when it comes to restraints and seclusion. So for Indiana, and this information is from 2013, so it may have changed since then. So for Indiana, they forbid the restraints that are harmful to children or staff, but failed to specify which restraint types, whether it be physical or mechanical. And then they state that parents or guardians have to be notified as soon as possible, but they didn't give a specific time limit to that. So maybe the soonest you could do it is like days later, and that seemed kind of long. And then restraint and seclusion is only allowed when there is a threat of imminent harm to that client or others. For New York, they permitted restraint and seclusion for imminent physical harm, property destruction, or educational disruption. Seclusion can be used continuously as long as it is directly monitored. Mechanical restraints are forbidden, but chemical restraints and restraints that interfere with breathing are not forbidden. So chemical restraints being like the use of pharmaceuticals to inhibit presenting a danger to themselves or others. And then parents must be notified, but again, there was no time criteria set for that. For Colorado, restraints and seclusion were only to be used in emergencies to prevent imminent physical harm. They forbid chemical and mechanical restraints, and then it requires a reasonable monitoring of seclusion without any expansion on what reasonable is referring to. And then parents or guardians have to be notified the same day that those were implemented. And then lastly, for Illinois, they only allow restraints when physical harm is imminent to themselves or others. They allow seclusion when physical harm is imminent and when education is disrupted. And then they forbid the use of mechanical and chemical restraints. Locks on seclusion room doors must automatically release. And then the staff must continuously and directly observe children in seclusion. And then parents have to be notified within 24 hours. And then I just wanted to list off a couple of the popular crisis management trainings that are used throughout our field that include seclusion or restraints. And that's going to be Safety Care, Crisis Prevention Institute, Right Response, Non-Abusive Psychological and Physical Intervention, and then Professional Crisis Management. And then I'm going to show our references. So these are the different references that we discussed throughout our presentation with DeRosa, Eblin, Furlinger, Fisher, Fox, Fuhr, Jeanette, Sullivan, and Vollmer. And then that's our presentation. So thank you so much for coming to it, and let us know if you have any other questions. Did anyone else have anything that they wanted to add?
I think that's it. Thanks for watching, guys.
Yeah, thank you.
Thanks. Sorry.